So welcome, everyone. My name is Alan Roth. I'm a practicing family doc as well as chair of family medicine at Jamaica Hospital in Queens, New York, and vice chair of primary care for all Americans, the vice chair of the board. Thank you all for joining us today. You're joining people who have come from 40 states and the District of Columbia. We just learned not from Alaska or Hawaii. So if you know those folks, have them join. 322 zip codes and others are joining this movement. The crisis in primary care is real, but I know better than anyone that there's no one out there to fix it for us. The cavalry is not coming, and there's no one fixing it but us. I am thrilled that we're going to hear from Melissa Ma and Sophie Ubaha, who are going to help us understand how California could approach fixing the primary care crisis. Many thanks to them and to Kevin Grumbach, their mentor, who has taught us all that it will take a social movement to fix healthcare in the United States. As you listen, think about the policy fixes that they propose, but also think about what we all have to do together in every neighborhood and every community to build this movement. Think about the process of connecting and mobilizing our families and friends and neighbors. That's what a movement is all about. A whole bunch of us working together to make sure everyone in every neighborhood and every community has primary care. That is what we are all about. We need to push our political leaders to make the changes Melissa and Sophie are suggesting. Please stay on at the end while our board joins Melissa and Sophie and Dr. Grumbach, if we're lucky, for questions and discussions. We'll be talking about how you can bring primary care to everyone in every neighborhood and community. It is now my great pleasure to introduce this evening Gabrielle Yarrow, one of our Zoom committee members, as well as the organizing Zoom committee of Renee Critchlow and the presenters, as well as John Wright, Brian Kaiser, and Patty Armstrong, our Zoom ACE producers. Take it away, Gabrielle.
Thank you so much. Hi, everyone. I'm Gabrielle. I'm a family medicine resident at Jamaica Hospital Medical Center in Jamaica, Queens, New York. And I want to thank you all for coming tonight. Being here makes you part of building this movement as we break the stranglehold to provide healthcare for people, not for profit, in every neighborhood and community. Primary care for all Americans. Please take a second and write where you are from in the chat. I know some of us have done it already, but let's keep it going. That way everyone can see who we all are as we work together to build this movement. To make this movement rock and roll, we have implemented our new policy on culture, tolerance, and respect as we work together to create a welcoming environment where everyone can contribute their unique talents and ideas equally. So no professional titles, please. Let's talk about the importance of being here together, engaged in this work, and the value of those ideas and commitments, which are what will build this movement at the end of the day. Tonight, we are here to both teach and learn from each other. We encourage you to ask questions, put them into the chat, and we'll have time at the end to answer as many as possible after we hear from our keynote speaker. We'll try to end the formal program right at 9 p.m. Eastern, 6 p.m. Pacific time, but we invite everyone to stay on for an interactive half hour at the end as we work together to discuss, plot, and plan. Now, I am very pleased to introduce our keynote speakers, Melissa Ma and Sophie Ubaha. Melissa and Sophie are health policy scholars at UCSF and also first-year medical students about to be in their second year. Thank you for joining us, Melissa and Sophie. Can you each talk a little about yourselves and your journey, and then help us understand what you've learned and how to get primary care to everyone in California?
Hi, thank you guys so much for having us. As Gabrielle said, I'm Sophie. I'm a first-year medical student here at UCSF, originally from St. Paul, Minnesota. And before I talk a little bit about myself, I'll pull up some slides and I'll let Melissa introduce herself.
Hi, everyone. My name is Melissa, also a first-year medical student at UCSF, and I'm originally from the Bay Area here in California.
Alrighty, so we're here to talk to you about a policy brief we as health policy scholars at UCSF developed, titled Healing the Foundation, the Critical Importance of Investing in Primary Care in California. And so just to talk a little bit about our motivations, when I began my first year of first year of medical school, I knew I wanted to pursue a career in primary care, and I knew I wanted to use my career to enact positive change. But I wasn't exactly sure where to begin, and I felt like I lacked a lot of skills and understanding. And so through participating in the Health Policy Scholars Program, I feel like I really, which I'll talk to you a little bit more about the details of, I feel like I'm so thankful for the opportunity to build skills and to develop the foundation to really engage in policy work and to be a physician advocate throughout my career. Melissa, if you
And
want to.
Sure. Yeah, so pretty similar to Sophie, I also came into medical school knowing that I was interested in primary care, specifically family medicine. I've always really been drawn to family medicine as I really value the holistic approach to care that family doctors take that really considers a patient's broader social context and also for the capacity to build those lasting, meaningful relationships with patients through all life stages. And in terms of my own interest in health policy and why I joined the Health Policy Scholars Group at UCSF, the more I've been exposed to healthcare and the more I've learned, the more I've kind of been frustrated seeing how fragmented and profit-driven our current healthcare systems are. And so through our work in the Health Policy Scholars Group and also throughout my career, I'm really hoping to contribute towards broader social change to improve patient health on both an individual and a systemic level.
Alrighty. So here's just a roadmap of what we're going to talk to you about today. And so jumping right in, a little bit about the program we're a part of, and I just want to kind of explain it in more detail. So we are part of a pilot program here at UCSF, just first year of what is the Health Policy Scholars Program, which was designed to bring medical students together to both advocate for primary care and develop the skills to do so. And so this curriculum had a kind of two parts to it. The first was more didactic. And so we were able to learn the basics of healthcare and healthcare policy. And we also heard from a variety of key stakeholders, including patient advisory committees, policy experts, organizers, and other key stakeholders about what exactly the landscape of health policy in California looks like, in addition to other things such as what makes a movement successful and really studying how to be active organizers throughout our careers. In addition to this more like didactic stage, we also had the opportunity to develop a policy brief, which we're here to talk to you about, in response to Senate Bill 770 or SB 770, which just went through the California legislature at the beginning of our academic year. And so this required the Secretary of California Health and Human Services Agency to develop a plan for a unified financing system, of which single payer was an option. And so given that this plan would already result in significant changes in healthcare financing in California, we saw this as an opportunity to advocate for revitalization of primary care and really emphasize that that was the foundation of our healthcare system.
So before we dive into the policy brief, we first wanted to just define what we mean by primary care. So the National Academies of Sciences, Engineering, and Medicine defines primary care as the provision of healthcare services that are integrative and accessible by clinicians who address the large majority of personal health needs, develop sustained partnerships with patients, and practice in the context of family and community. And just to specify, by using the words clinicians, we include nurse practitioners, physician assistants, as well as doctors. Next slide. All right, so the first section of our brief starts with an overview of the value of primary care, and I'll keep this section brief as I'm sure you're all familiar with the value that primary care brings. But we really wanted to emphasize with these graphics and statistics here how evidence shows systems that invest in more primary care have better population health outcomes, including increased life expectancy and decreased hospitalizations, greater patient satisfaction, decreased overall healthcare spending, and greater health equity. Now I'll pass it back to Sophie to discuss the current state of primary care.
Yeah, so like many other states, primary care in California is in crisis. And so we wanted to formulate this in our brief around kind of a financial like cord running through. So although California does spend more than the national average on primary care, we can still see that this pales in comparison to other high-income nations, and this underinvestment has real consequences. And so on this map, on the right of your screen, you can see the areas highlighted in blue are all counties where there are not enough primary care providers to go around. And the demographics of these counties indicate that the disproportionately Black, Latinx, and Indigenous Californians who are facing the brunt of this shortage, further exacerbating other inequalities in health. For our brief, we wanted to kind of make this information more accessible and really hone in on 4 main areas of the consequences of underinvestment in primary care. So the first 2 are quite common. So people who are unable to access primary care often end up seeking that in emergency departments or end up hospitalized for things that could have been prevented earlier on. And it's really intuitive how these 2 things can contribute to system strain. We also wanted to focus specifically on provider burnout, as primary care providers face disproportionately high rates of burnout. And this is for a variety of reasons. But one thing we really wanted to hone in on was the fact that there are simply not enough providers to go around. And this is, unfortunately, the data suggests, driving people from the field. And this contributes further to fewer new primary care physicians entering into the field, creating a sort of vicious cycle. And so that requires intervention. And this is something that hits home to me and hits home to Melissa. As medical students, we see very few of our peers express interest in primary care, and we understand that this is a national trend. And so to resolve this issue, resolve this system strain, we are claiming that we need interventions at a systemic level and at a policy level, which is what Melissa will talk to you about next.
All right, so given the disparity that we have between the value of primary care and current levels of investment, we are advocating for these following evidence-based actions. So number 1 is to increase primary care investment from 6% to 15% of total healthcare expenditures. And so by setting a mandatory target for the SB 770 plan of 15% of healthcare expenditures, we would have additional resources that would pay for integrating behavioral health professionals, community health workers, and other staff into primary care teams and recruiting more primary care clinicians. And our second recommendation is to ensure that all Californians are linked to a high quality primary care medical home to create stable primary care relationships. So a unified financing program must assist Californians in overcoming barriers to establishing and sustaining relationships with their personal primary care teams. And so Covered California has been a national leader in assuring that all their enrollees in exchange plans are linked with a primary care practice. So this sets a precedent for universal primary care linkage under a unified financing system. And our third recommendation is to implement a comprehensive primary care workforce development program to support training programs and increase the supply of primary care providers. And we propose that this is done by, number 1, expanding the number of primary care physician and residency positions, especially in resources with workforce shortages. Number 2, optimizing the role of nurse practitioners and other health professions as part of the core team. Number 3, expanding and strengthening loan repayment programs for primary care clinicians. And number 4, recruiting and training students from under-resourced communities for careers in primary care as diverse primary care workforce that reflects the demographics of their patient population is really essential for establishing an equitable healthcare system. So in conclusion, as medical students and future physicians, we really hope to witness a radical change in the valuation of primary care in California. Despite the undeniable benefits of a robust primary care system, primary care has been chronically underfunded, leading to reduced access to care for millions and higher rates of burnout among primary care workers. We're in critical need of transformative reforms that center primary care as the foundation of our health system. We believe that SB 770 offers an opportunity to rebuild primary care in California and initiate broader change across the US. By integrating the recommendations we outlined in this brief, SB 770 can help foster a healthcare system that prioritizes holistic care, increases accessibility, decreases cost, and enhances the well-being of all Californians. So on our last slide, you can find links to our full brief. We welcome your feedback and questions, and thank you so much for your time.
Thank you, Melissa and Sophie. Do you have any questions for Melissa and Sophie? Please post it in the chat. By joining and learning how communities can provide primary care to everyone and bringing one new person or more each week, we'll build this movement together. How did you do inviting someone new? Anyone on here that was invited to come tonight for the first time? If so, raise your hand or give us a thumbs up. Our work groups still need more people to roll up their sleeves and be a part of the work we are doing. Please click the volunteer button in the Contact Us section of our website to tell us how you can help. Together, we can make sure that everyone in the United States receives equitable healthcare and gets equitable health, regardless of where you live, how much you earn, what community you come from, or what you look like.
Thank you, Gabby. Okay, are we ready for some questions, ladies? All right. So if you do have a question for either Melissa or Sophie or about the program that they worked on, this is a lot of the work that we've been doing in some of our breakout groups. They have done an excellent job of, outlining sort of their plan of attack. So feel free to, ask them how they got to where they are. But let's start off with this. How does California measure the extent to which all its residents have access to real primary care? Could it develop better measures?
I think we have Kevin Grunbach also on the line, who's going to help us field some
Hi,
questions.
Kevin.
I think this would be, we are here to offer the medical student voice, but I think this might be, and we're happy to comment, but I think this might be a better question for him.
Okay, well, before you answer, Kevin, do you mind just, telling us who you are and,
Sure.
how we got you here tonight?
Sure. Hi, that was a beautiful job, Melissa and Sophie. Thanks. So I'm a family physician, still practicing. I'm a professor of family and community medicine at University of California, San Francisco, and just a long time policy researcher and advocate, and just am deeply committed to making primary care work for the people of this country and the people who provide the care. So I'm thrilled to have primary care for all Americans developing, because I certainly think it's going to need a really broad collective effort. And for me, maybe it's, like some others on this, as you get older, you some ways get more radical because you realize all the things you've been tinkering with over the years haven't gotten you where you need to go. So I think I'm all in on, we really need bold, much more radical reforms. And so I thought, well, how do we get medical students more involved and activated early on? So that's where we piloted this primary care health policy scholars program at UCSF. Sophie and Melissa and another about dozen students are part of it across all the different classes at UCSF. And it's sort of what's inspiring to folks of my generation to have this energy and enthusiasm and vision and just brilliance of the next generation of people who are interested in entering as primary care clinicians. So that's who I am. That's a context here. So I've been the kind of faculty sponsor for this great policy scholars group. So California. So there are, California has. There's a California Health Interview Survey that's done every year. So that's, one of the basic tracking mechanisms to look at what % of people in the state report a regular source of primary care. There are other measures that are tracked around, preventive services received. And one of the things that's shocking for a state as progressive and deep blue politically, California looks quite bad on many of these indicators compared to other states. Like a relatively low percent of people with a regular source of care. A lot of other indicators are really quite embarrassing. So you've seen the primary care shortage areas where Sophie and Melissa, what we thought about a quarter of people in the state live in a official primary care designated shortage area. So there's a lot of tracking measurements to tell us how badly we are, just like so many states, and to allow us to track, can we make progress on those goals?
Thank you for giving us that information. We have a question from Lynn Blanchette. Lynn, do you mind coming off of mute and just asking your question about, the role and the value of your NPs? Go ahead.
Actually, I asked about registered nurses. So those nurses who don't have the advanced certification to practice as nurse practitioners and clinicians, but specifically including them in your planning, bringing them to the table when you're setting this up. We're often listed in the other health professions, right? And so I'm not clear if you got input or if you anticipate that registered nurses will be part of the planning that you're doing. So I just, as a registered nurse and a registered nurse professor, educator, and a lifelong provider of primary care, I would like to hear about where you see that happening.
I wonder, yeah, what do you think about how to, we broaden this or build more cross professions, collaborations, maybe even at the student level? Yeah, Sophie, Melissa, do you have thoughts on that?
Yeah, I think we're at a really early stage with this brief, and we're really hoping to get a variety of input from collaborating with our fellow nursing students to bringing in just pretty much anyone who wants to comment on it. So that is like people at all stages, all levels across the healthcare system. I think, like kind of it's been hinted at, this really can't happen unless we all engage with it. And RNs are such an important and vital part of the care team. I think it really couldn't happen without them. And so we're definitely hoping to kind of expand who we get input from. And I think RNs are up there. I think we want to engage more with I think we as like medical students often refer to it as patients, but it's really just people. It's like who we all are, and really just get input from pretty much everyone. So I don't know if Melissa has more to say on that, but that's kind of, I think we're in the early stages and we're really welcoming it, and we welcome any suggestions you all have.
Melissa, did you want to add any additional comment to that? I think this is a discussion that we hear time and time again about, how do we invite more voices to the table? How are we making sure that we have the right cross section? Wayne, I see you have your hand raised. Did you have a comment to add to this?
Well, I had a different question. Okay. I guess I wanted to say that Melissa and Sophie, your presentation was fantastic. I had the privilege of reading your brief, and I thought it was incredible. I really enjoyed reading it, and it was really high level. And Kevin, they give me hope for the future. And my question for you both is, how much time do you have allotted for this fellowship? And do you get a stipend, or is this a volunteer fellowship?
Yeah, so I can go ahead and answer that. So this is actually the first year of this program. So I think it is still evolving in how it is structured. But as of now, each student does get a stipend of $500 per quarter, which is great. And I think as we move year to year, different students will kind of, join the group and leave the group depending on what year of medical school they're in, as we have members from every year, from first to fourth year. And yeah, but was there another part to your question?
Yeah, there's no credit for this, right? So it's not a formal course catalog course. It's really a volunteer group who wanted to get more immersed in this. We kind of go over a lot of readings and things to get started, and then this. So Wayne had the good fortune of a gift to the Department of Family and Community Medicine that is where we get the resources to provide the stipend. So again, it always helps to have a little bit of, funds to be able to invest and support folks. And then I think, I don't know, Sophie and Melissa, it seems to me partly, I don't know, the title was intentional, right? That this is like did you put on your CV when you applied for your summer fellowships and things like that? You both are doing summer research or programmatic. And Sophie, I know we have Wayne Jonas on who's been very involved in integrative medicine. Sophie, you may want to even just mention your interests and what you're doing this summer. But maybe do you want to just comment, like, why would students want to join a program like this if you're not getting credit for it? Other than, and probably $500 probably isn't the answer. So
Yeah, I can chime in. I think I saw this program and I was really super excited. I think, like I commented earlier, I think like the more that I learned about like healthcare and the healthcare system, the more that it really became apparent to me that change like really happens at a policy level. And yet from my background of like biology and like basic science that kind of leads you to med school, I really felt like I didn't have a really good grasp on policy, on how to read policy and how to advocate for it. And so for me, that was why I chose to engage in this program. I think we've had a really positive response in terms of other students. And then I think some things that we have like on deck for, if not next year, like future years, is trying to kind of develop a curricular model that can be disseminated to other universities, maybe starting with some of our partners in California, so like down at UCLA, kind of cooperating with other like maybe family med interest groups or things like that, to really be able to kind of spread this in terms of, I think that there are a lot of medical students. There's some who already come in with a lot of policy knowledge, and I feel really, really grateful to be able to work with them. But I think also providing a space to build those skills so early on in our career, I'm really thankful for, and I feel like now I have somewhere to go from.
Thank you
Well,
guys so much.
I was just going to say, I think it's an extraordinary idea. And when you're ready to collaborate, Tufts Medical School in Boston would be a grateful collaborator.
hey,
I know we've got
yeah, Patty, I know we got to end, but I know just Wayne, I just know, or you have a hard stop. All right, because
we do have some more time for discussion in just a few minutes. So I know there's a lot of interest because you have really hit on something that I think is so important for us, which is activating people to make real change. And I think I can see a lot of head shaking. I can see a lot of excitement happening. So I'm sure people will want to join us in just a few minutes. Thank you guys so much. Michael, did you want to chime in here really quick as we wrap things up?
I just want to help us wrap. Melissa and Sophie, I don't know how to thank you enough. You gave us a great roadmap and showed us how much we have to do. We now understand something of the what. Now's the time for us to focus on the who and the how. The who is first hundreds and then thousands and then hundreds of thousands of people from every walk of life. And part of our challenge is going to be to bring those people in and make this something everybody can understand, regardless of who you are or where you're from. The how is helping people in all our communities understand it really is possible to provide primary care to everyone. And it's possible to make a healthcare system that's for people, not for profit, and to strengthen democracy as we do it. This means getting work groups started in every neighborhood and community, in every city, in every state, all across the country, and working with community organizations, mosques, churches, and synagogues, with Rotary and the League of Women Voters, with FFA and with social clubs, with barbers and hairdressers, and with Boy Scouts and Girl Scouts, so everybody knows and everybody helps. Movement building is a crazy, huge undertaking, but the folks with something to sell are going to push back. And they're the guys who are taking something like $2.5 trillion a year out of our communities, and they're not going away just because we say pretty please. They will join us when we organize, and they feel like there's something happening here. Remember that healthcare impacts everyone. When we work together, there's nothing we can't do. Primary Care for All Americans is the only national organization pursuing local and state level change to recognize primary care as an affordable, essential service that's proven to improve public health and lower costs, to continue building that momentum and continue building our movement. And more importantly, what all Americans need and deserve, we also need your financial support, regardless of the level. So please consider investing $10 a month or more to support our critical work. So let's all reach out to colleagues, to family, and to friends. Let's spread this word. This isn't a Republican thing. This isn't a Democratic thing. It's an American thing, and it's there to help bring democracy back and make it stronger.
All right, everyone. In 2 weeks, we will meet again and break into work groups. We encourage everyone to find someone new to get involved in this impactful movement to our next Zoom meeting, which is on June 25th. To adjust for summer schedules, we will meet only once in July on the 16th and then in August on the 13th. We'll be talking about and learning about how to build engagement and community and how to make movement building exciting and fun for everyone. So come one and come all. Register on our website, www.primarycareforallamericans.org. And while you're there, click volunteer in the contact us section of the website to tell us how you'd like to be an active part of our movement. And please click donate to support our work together with a contribution. Every little bit helps. We need and appreciate every single one of you for helping to spread this movement across our nation in order to get the change we need and you deserve. Healthcare for people, not for profit. Primary care for all Americans.
Well, we want to have you guys just take a quick minute to complete our survey. We dropped that link in the chat because we want to hear from you. This isn't about my voice or Michael's voice or Gabby's voice or any single voice. It's about us coming together. And so this is an opportunity to hear directly back from you. Speaking of hearing back from you and chatting, if you'd like to talk with members of the leadership team, stay on the call. We're going to transition right over into some additional questions and conversation about what's going on, because we want to grow as a community, right? We want your voices heard and we want to be able to move together. For those of you that have to hop off though, we will see you on June 25th. Otherwise, Melissa and who else? Sophie and Kevin, are you guys staying on for just a little bit to answer a few more questions from people and continue our conversation? Wonderful. So I am going to call on Paul, who has been so patiently waiting with his hand raised. Paul, did you have a question or a comment for the group?
Well, first of all, I want to say I was a family doctor for 39 years, and I've talked with Michael Fine, and I don't find a single word I've heard tonight to disagree with. You're all right on. You're doing the right work. In the last year, not only has this organization started, but there are multiple other ones that have begun. I'm now in 3 of them. This one, Medicine Forward, and the Healthcare Reinvention Collaborative. These young medical students have no idea how much support they have out there. I personally have yet to find a caregiver who thinks the current system can sustain itself. It doesn't matter who you talk to, neurosurgeons, primary care doctors, nurses, or respiratory therapists. No one thinks this can work. So your support for revising how we do things in America is absolutely huge. Go for it.
That's so encouraging. I hope you guys feel encouraged by that, because that is, that is what we hear time and time again. There is a lot of work to be done, but people are hungry for it.
Absolutely.
Let's hop over here. I see Wayne Jonas. Are you still on the call with us? Oh, I see him there. How are you,
Yeah,
sir?
I'm here. I'm sorry. It's getting a little dark and I'm outside, but I don't want to go inside, so I apologize.
That's okay.
The weather is so nice and the sun is setting, but I am here. So just pretend I'm off camera, but I can hear you.
Wonderful.
I
Well,
I also have to keep an eye on my dog who's out here. So anyway,
I
want him
hear
to
that.
run off.
I know that you had made a comment about some of the health coaches and complementary practitioners being included in the array of the primary care workforce. Maybe you have
Yeah.
a comment on that, or maybe one of our
Well,
work
just that was
groups?
actually a question to Sophie and
Yeah.
Melissa. You mentioned in your talk, other providers besides physicians, and obviously can't do a laundry list of everything, but when you talk about team care, I think especially if we're going to address behavior change and lifestyle and that type of thing, health coaching is essential. I don't know about you, but I never learned the science of behavior change, and I haven't seen it in many curricula. Behavioral health has been sort of labeled now as mental health, but I'm not talking about that. I'm talking about behavior change. Smoking cessation writ large, because we know that nutrition, sleep, physical activity, etc., fundamentally drive many of the chronic diseases that we that then end up costing us a lot of money when we don't prevent them in that way. And that probably isn't going to come from physicians, because we don't do that. We treat diseases, right? Yet we need to go upstream, meaning upstream in terms of people's lives, upstream in terms of the determinants of health, personal determinants of health, and enablers that allow people to engage in their own healthy behavior or not, and address those. And we sort of need the handcuffs taken off of medicine to, get that embedded into the community, and the community and the healthcare system have to work in tandem and hand in hand to make this happen. So I'm just wondering. I said more than my question here, but where do health coaches, for example, fall into this? Is that a part of the workforce that you all have been talking about there in California?
Yeah, I think I'll start us off. I think we're really privileged that we got some exposure to health coaching in our med school curriculum. And so kind of a little bit just really understanding like how important they are to leverage. I think similar to building like a movement writ large, revitalizing primary care, really, like Melissa was saying in our presentation, I think it really is a team effort, and it's finding ways that we can integrate. I think as integrative medicine kind of picked up, as Kevin kicked off, that's kind of what I'm spending my summer researching. I think it's really kind of breaking down this line between medicine and then non-medicine, and understanding that it's all people and it's kind of all life, and how can we use everyone on the team, from health coaches, from nurses, from LPs, like really just anyone, and bringing them all together, because we're all in it together and we're all fighting the same battle. So I think we're trying to be as expansive as we can and hopefully build all of those collaborations.
Well, that's great. And California, other medical schools I know are very interested in this. I worked a lot with UCI and some others, UCLA, and I don't know if there could be a coalition of medical schools in California who came together. I think that would be very powerful. There we go. We got a light.
Wayne was willing to walk back inside just for you guys. So,
well,
no, I think that, there's some great conversation happening around, how do we lean into one another? How do we help to not just hear what others have to say, but how are we allowing people in their expertise? A little cheating is that my mom is a nursing professor herself, and she jokingly overheard one of the conversations as she was taking care of my kids, and she said, it sounds like a lot of doctors are starting to become nurses, just because there's such a huge behavioral aspect to the nursing program, right? So I mean, it's great because you all are leaning into some of the areas that have been so siloed in the past, and it's really, as Michael says so often, about us coming together to really lift a lot higher. I'd love to, I see Lawrence has his hand up.
Can I just ask,
but
what are the,
yeah.
I'm sorry, I know Larry's got his hand up, but what are the chances of this, and what's the timeline for this passage of this SB 770? I mean, are you all, is it being actively taken up in California by the legislature and the government? And mean, is that going to happen in the
So wait,
next year?
all right, so maybe
Going
I
to
can,
happen
so
after the next election?
so this bill, SB 770, has actually passed. So let me give you a little more of the context,
I see.
folks.
I see.
And Governor Newsom of California, fairly in his first term, came in saying, "Yeah, I want to do something on health reform. I did universal coverage program in San Francisco when I was mayor. I'm, actually open to thinking about single payer." So he and the legislature appointed a Healthy California for All commission that had a lot of blue ribbon type people on the commission. And much to a lot of people's surprise, they actually, at the end of this, in a report released in 2022, recommended that California move to, quote, a unified financing system for healthcare. And many people interpret it as saying, well, that was a bit of a euphemism for single payer. And they had already done some of the work and say, well, here's a couple of barriers for a state-based universal unified financing program. You have to figure out how to get Medicare and Medicaid to fold in, particularly Medicare being harder for a state program. How do you deal with things like ERISA waivers for the policy wonks here for self-insured employers? So they were already starting to say, we need to start thinking through that. So that came out, and then the legislature had a bill move forward to say we now need a plan to implement the design of what a unified financing system would look like in California. It charged the Secretary of Health and Human Services in California to develop the plan to be drafted by January 2025 and finalized by July 2025 with, variety of input into that process. So we're in the phase now of the Secretary of HHS has a kind of group that's starting to work on what should this design look like that we would then take to the federal government to say, here's what it would look like for unified finance in California. Is it really going to be single payer? Is it some all payer like Maryland type plan that has a Medicare waiver for hospital payment? So that's in process. So Wayne, it's already actually enacted and signed by the governor. It's not to actually implement like single payer or something, but it's saying it's to move California further on specifying what a more ambitious, universal, more coordinated financing, maybe even single payer system would look like. Clearly, there's a lot of single payer advocates that are pushing the government. And so I think the timing here was to say, a lot of you folks who think all the time about healthcare financing and payment and the problems of administrative waste and profits and things, do you realize like none of this coverage stuff is going to get us where we need to go if you haven't thought about the delivery system and this huge deficit in primary care? So that's where I think the students' policy brief came in, because a lot of the people in the coalitions that have been pushing SB 774 had very little understanding of like this crisis in primary care. And so that's where some of the scholars presented to the SB 770 coalition of unions and nursing unions and others, and trying to really get primary care inserted into this. So I think that's it. And some of this is saying, well, if the state decides a whole unified financing single payer would be too much, maybe a starting point would be to say, let's start with a primary care for all program as a more incremental step, perhaps, to really address the biggest hole, both people who need primary care and the infrastructure to deliver it. So we're on this process. It's all politics. The government took a note. And what's Gavin Newsom's political presidential ambitions? It'll all. That's what
it'll flow out. Well, I mean, again, others have their hands up, but single payer aside, if we just got rid of the idea that this had to be single payer and said the 15% that you all recommended here in your briefing, that had to be invested in primary care, and that the accountability metrics had to be health, the quadruple aim, right? The quintuple aim, I'm sorry, the quintuple aim. Then, and we have metrics for that. Then, I mean, let the innovation begin, right? So anyway, it was fabulous. I love the simplicity of what you did. I love the focus of what you did. I want you to bring it to Washington, and I'll pay for your plane ticket. So
that's awesome. No, and I think this is part of the importance and the real value of adding more voices and more groups to come to this call, right? We've heard already that there are some other groups popping up in all of this as well. So again, just a plug to follow us on social media. Those are going out. we send out a newsletter every single week. There is a ton of information in that. Forward that on to other people, engage them, because I have heard more times tonight than I think I have even in the last few calls. Oh, that is sparking an idea for me that I can actually implement over here. And that's really what movement building is going to do for us. So Larry, can I call on you to ask your question that you've got your hand up for?
There we go. I've unmuted myself. So the third priority that you folks mentioned in your briefing, which is to address really who gets into our health professions into schools, whether it's medical school, nursing school, et cetera. Right now, 75, this is for medical schools, 75% of the students who are getting accepted into medical schools are from families of very strong means, let's say. They're not the kids getting in who are first generation to college families, who are from rural communities, who are from inner city communities. Those kids have a difficult time competing because they don't have the enriched support in their high schools. And one of the groups that's missing, I think, from our ensemble here are representatives from those groups like HOSA and others who, if they were to get into medical school and dental school, are much more likely to be excited about primary care. They're much more excited about practicing in the future in communities like what they grew up in. So I just wanted to put that out there for the group's consideration.
Thank you for that, Larry. I appreciate that insight. Michael, did you want to comment on that and then add your question in there?
Sure. Mine will be a quick comment. The policy stuff, I just want to remind everybody that as important as figuring out the policy is, building the base is equally important, because when it comes time to get stuff passed, we need lots of people working together, advocating in their own communities. And we have kind of a moral obligation to deliver something that's meaningful to every single community. I'm speaking from Rhode Island, where in 2013, we developed an idea called the Rhode Island Primary Care Trust, which was single payer for primary care, had a good base, was well thought out, got well reviewed, and went nowhere because we hadn't put the base together first.
Absolutely. And again, this goes back to what I was saying earlier of there's such good idea share that's happening here and really inspiring. Sophie and Melissa, I don't know if you could see all of the like ear to ear smiling faces as you guys are presenting on this information, and just people, you're re-energizing people. That's part of what happens time and time again. We hop on this call, we're re-energized to do the work, because I believe Wayne Altman said he hoped it would happen in a year or two, and then 5 years later, he's still going. Did you mention that a few weeks ago? Like, it just takes a long time. This is a lot of work. And so having new voices added in and, coming together, that makes a huge difference. But we need that base, right? We need that group that's standing behind saying, yes, we want this. So Scott, can we have you add into our conversation?
Well, Melissa and Sophie, I really am inspired by you. And it means so much to have young, bright faces doing the kind of work you're doing right now. So just really appreciate how inspirational you are and what a big difference you make. We had, over 30 people here tonight, and all of them are listening to you, and all of them heard kind of your encouragement and support. So that keeps us going for another 2 weeks or 2 months or 2 years, and that makes a big difference. So thank you. I wonder, in hearing the conversation, I'm board certified in integrative and holistic medicine. So Sophie, I love you, and don't give up, never surrender. And I wonder if what we're not really talking about is primary care healers for everyone in America. And, I get really frustrated with the conversations. Do nurses belong? Do dietitians belong? Do masseuses belong? Do chiropractors belong? Because I think it's a stupid conversation. yes, absolutely. We've got to meet people where they are and help them improve their health and well-being, which, as Wayne Jonas has taught me, 80% of that is not from a pill, procedure, or surgery. It's from a therapeutic, quote unquote, relationship with a healer. And so I would really encourage you all as you go forward in your career, long after I'm gone, to really focus on becoming a healer. I think it's a mistake to be a doctor or a nurse or chiropractor or a masseuse or whatever. It's all about how can I develop my skills as a healer. And as Wayne and others have pointed out on the call tonight, the thing that really I find in developing systems, because Alan Roth, Michael Fine, Wayne Jonas, Larry Bauer, Wayne, I mean, we're systems builders, right? We look at this as a system of care. And at the end of the day, it's how do you use data and information to empower people to meet people where they are to have them take the next step in their healthcare journey. So I really hope you'll latch on to the concept of healers and everyone in America. And I also hope that you heard what Mike just said, which is the way I believe, as a person who has pushed this rock up the hill now for 50 years, I really, really believe that we're going to separate primary care off from all other specialties and facilities. And what will happen is primary care will be funded to be healers and supporting people, and let everybody else fight for the fee-for-service dollars. So there's a divorce that's going to occur. We, primary care healers, don't have to fix specialty and facility medicine. Let them go fight it out. We just have to make sure that every American has a great healing community in which to find support and to grow their well-being. So last comment I just want to make is, if you haven't looked at the email today, the conversation about the hybrid practice and what's going on was amazing. So here's to those of you who put that together for Primary Care for All Americans.
That was Brian.
Very inspirational. Yep, Brian. I knew it was you. I didn't know if you wanted to be called out. You have admin on, so I didn't know if you wanted to be called out that way or not. But Brian, it was outstanding, and I've already sent it to several other people. Thank you.
Thank you for that,
Scott. I'm glad you appreciated it.
There's a lot of work being done, and I hope you guys are all really proud of the work that we are doing. We will be joining back together in 2 weeks. So it looks like we had about 30 people on the call. If everyone brings someone back, we'll be 60 strong next week. Or in 2 weeks when we get back together and we start looking at work groups. Sophia and Melissa, I hope you guys and Kevin are able to join in. Have some of your colleagues join in. We have work groups that are focused on state workbooks. And I believe we have one that's for the state of California. I'm sure they would love to hear more in that group about what you have going on there. We are working on social media and engagement. I've seen a few different times actually up here. Pat talked about, who is saving this money and how do we get them engaged in the process of knowing that, hey, there's some real dollars back in your pocket, So Larry runs our engagement. What did you guys rename your group, Larry? I know it's not engagement anymore. It's something much more fun and exciting.
Well, we added the word fun to our
fun and engaging.
Yes. Yeah. So
I'm adding exciting.
This has got to be fun, exciting. There's a lot of words that we could use, but we need to make it that way so that people get excited about joining.
Absolutely. And we're working on social media. We're working on a massive work group plan, so that we have ways to enact change. But as Dr. Fine will tell you time and time again, we need a movement. We need people to join us and to know, and we don't just need medical professionals. We need the grocer. We need the person around the corner. We need your neighbors joining in, because they are the ones that are going to utilize the system, and that really it's going to impact them and having that great health care and not a system that is so broken. So with that, Michael, any last words of wisdom for this group before we send them off for 2 weeks?
No, you've got it covered. We need everybody. Come back and bring 1,000.
Well, with that, it's been great to see you all. Unless there's another question out there for the team, we will let you guys go just a couple minutes earlier. But thank you, ladies. Thank you, Kevin, for your insights. This was a super informative evening for all of us.
Yep. Thank you, Melissa. Thank you, Sophie. Great job.
Thank you, Melissa and Sophie.
Yeah, well done.
Thank you guys for having us.
Thank you for having us. Bye.